So we have CT for this 40-year man, and history was nausea, vomiting, and even hematemesis since one day. And this was CT with contrast done in the ED. So we see nothing else except this finding. Okay, maybe I can enlarge it. So on the axial, we can see these lesions. So we can see it's mainly along the mesentery, and it is on both sides of the superior mesenteric vein, superior mesenteric artery, but without any mass effect. And also we can see on the coronal similar findings. On laterally, they look a little bit different. Looks maybe slightly bigger. I'm not sure, maybe like peripherally enhancing, or maybe even
clustered.
cystic.
It's clustered in some kind of like a contained space.
Sure, yeah. So
The non-lateral part to me looks like mesenteric lymphangiomatosis, but the lateral part almost looks like maybe it bled or like more complex.
yeah, so I think we looked at similar case on our probably a few months ago. So as a resident, like we do not see this kind of cases frequently. So when we see these mesenteric lesions, we initially think of maybe lymphoma, or all those non-specific mesenteric panniculitis or sclerosing mesenteritis. But here, especially the lateral portion, it looks kind of cystic. And when we measure Hounsfield unit, it was fluid density. But just to confirm, we got MRI. And in MRI, we can see, I can pull up this T2 axial, so you can see all these T2 bright lesions.
Nice case.
T2 bright lesions, and post contrast, we can see peripheral enhancement only, no nodular or suspicious solid enhancement. Yeah, so the patient was discharged, but yeah, I think this was a case of mainly mesenteric, but also slightly retroperitoneal involvement of the diffuse lymphangiomatosis. Yeah, do you agree? Or
yeah, I do think though that something happened to that lateral part, like, and he said he was vomiting and things, so like maybe some acute thing happened. I did read recently, like last week I presented that lymphangioma, and they can hemorrhage in them, and they can be more complex. So maybe like, yeah, maybe there was some kind of acute inflammation or hemorrhage along. Oh yeah, actually, can you show the T1 pre? Is there any blood products you see over there?
Oh, sure.
I do feel like that lateral part looks more inflamed, but I agree that it's a really cool case.
So our T1, not that good, but yeah, we don't see any obvious T1 bright areas. And it's pretty weird. When I was reading one of the case report, they said this could be asymptomatic, but also could result into GI bleeding and even like protein losing enteropathy. But obviously interesting was this could lead to GI bleed. So that was interesting. And like for surgery, if it is limited, they could do resection, because there is obviously risk of, like gradual increase and then probably even mass effect or like hemorrhage, and then bleed. And one of the cysts could, like even torse. So all those complications. But when the involvement is such extensive, then I think radical resection would be really, really difficult. So at least for this guy, the surgeons did not do anything. So probably wait and watch for now. Yeah, that was my first case. Sorry,
I think we bring this up every time, but Steve showed a case of this where it was treated with some kind of immune modulator, I think, and it shrank away. So I'll try to look that up and tell you guys in a few minutes.
FGFR receptor antagonist. Is it a TKI?
TK. Oh,
Tyrosine kinase inhibitors.
okay.
Awesome.
That is my first. No. Okay, so this is the second case. So this is 90-year patient, and this guy has a lesion in the pelvis, as we can see, a big T2 bright lobulated lesion, and we can see its communication with the anal canal. So it looks like this is continuous, and it's mainly in the ischiorectal fossa and ischioanal fossa. Okay, let's see. So below it's going into the ischioanal upper ischiorectal fossa or fat area. And this is the post-contrast, and we can see the internal, there are so much internal enhancing septation and nodular solid components. Here we can see again, it's continuous with the anal canal internally. And in the restricted, it also shows restricted diffusion. The solid components, they show restricted diffusion. Okay. This is the coronal. Here you can see this lesion. Maybe I can show it in the T2 coronal better. Okay. So here we can see the levator, and not sure. This is definitely outside the internal anal sphincter, but not sure if it is between the internal and external anal sphincter. Anyways, this thing is continuous downward. So this was anal fistula, and in the anal fistula, we have this T2 bright lesion with internal enhancement. And this was biopsy proven mucinous adenocarcinoma. However, interestingly, this patient also had some other findings. Where is it? I'm trying to pull up. Where did, okay, here. So here we see the mass, but if we see there is some lesion in the right gluteus maximus muscle, it has some thin enhancing septation. So maybe a typical lipomatous tumor, could be simple lipoma or maybe a little bit more complex. So low-grade liposarcoma cannot be excluded, but if we go a little bit higher, we see this lesion, and it is also in the retroperitoneum. This was also seen, okay. This lesion was also seen on the MRI of the abdomen, where there is extensive retroperitoneal fat, and this was the lesion that showed enhancement, and this was biopsy proven retroperitoneal liposarcoma. But the story did not end here, and this patient also had this is not biopsy proven, but most likely an RCC, so multiple findings. So anal fistula with mucinous adenocarcinoma, and then retroperitoneal liposarcoma, and possibly low-grade lipomatous tumor in the right gluteus maximus, and also left kidney showing probable RCC. So yeah.
So did this patient have like a hereditary syndrome?
We didn't find anything in our EPIC, and also we searched in the web, but there's no specific things to tie all these factors. But
you said he was 90, right?
Yeah, 90.
So for me, this is like, you know, oh, I don't know. First of all, it's like Hickham's dictum, like you can have as many diseases as you want, but especially as you're approaching 90, I could see how you could develop so many different things, you know?
Yeah, maybe.
But I do feel like this this large mucinous one would be symptomatic before it would get this size or something. But yeah, that's a great case. Nelly had brought up for this anal tumor aggressive angiomyxoma, which I thought was a good thought. And we usually see that in women, but it usually has that kind of like appearance where it's extending vertically into the perineal area. I was just curious, does anyone know if men get those? I feel like I've only seen them in women, but okay, I can look that up. Thank you so much, Anna. Nelly, do you want to go?
Yeah. Would you be able to pause the recording, please? I've presented this case already. And if so, that's okay, because I think there's always great learning opportunities, and repetition is the way to go for learning. So this was a patient who had remote transplant nearly a decade ago, and then followed up elsewhere, and then came in with elevated transaminitis. And then we got imaging, which looked like this. So the patient had an aorto conduit, aortohepatic artery conduit right here, and that's occluded, like you can see. And then more importantly, maybe the patient had all of these kind of central hypodensities. Any thoughts about what you think that is?
I'm wondering about PTLD. I feel like all the fat planes are lost.
Great thought.
It also looks kind of fatty. Swachchhanda
A
is saying
patient is a patient is acutely sick.
okay, Swachchhanda is saying biliary necrosis.
Yeah. So there's, exactly. So it follows the kind of the path, central kind of ducts. And so we got an MR, and then the MRI is very impressive and looks like this. And then I'll show you the MRCP. So there's a severe stenosis. There's like there's complete flow void at the CBD anastomosis, with severe dilatation of the intrahepatic ducts, with extensive edema around the bile ducts, which was accounting for the hypoattenuation on the CT. And then we had also seen that complete occlusion of the hepatic aortal conduit. And then so we went ahead and recommended ERCP. And so they did, and here's that tight stricture that they went ahead and balloon dilated. And then the patient had a follow-up imaging sometime later. And then this is what the follow-up looks like. LFTs nearly resolved. The transaminitis, bilirubin went down. There's still some reactive, like parenchymal changes on the contrast enhanced imaging, but it was sort of trending the right way. And that edema resolved, but there's still pretty extensive, like non-enhancement, hypoenhancement of that area along the biliary ducts. There's a stent in place with extensive pneumobilia right now, and the LFTs improved significantly. So this is a case, and then the MRCP I thought was really great because it's just a great example of what ischemic cholangiopathy, chronic ischemic cholangiopathy can present with. You get central ducts, which are markedly diminutive, and then the peripheral ducts are dilated. So I thought this was a really beautiful case of what ischemic cholangiopathy looks like after addressing the obstructive component. Yeah.
Nelly, so do you think the main issue was the hepatic artery thrombosis or the biliary stricture?
I think it added, I think it was like cumulative.
Yeah.
So I think there was underlying ischemic cholangiopathy, and then the obstructive cholangiopathy was like added on top of it and led to the patient's acute presentation. The patient also ended up having positive cultures, likely from the obstructive cholangiopathy. And then once the obstruction was resolved with balloon dilatation, then just was like huge improvements after the intervention. But there's still ischemic cholangiopathy like that we see definitely from the occlusion.
Yeah, cool.
One question, doc. So why was that aortohepatic conduit made?
That's a, I presume there was, yeah, I don't know exactly, but I know that we do this when patients have had complicated hepatic artery thrombosis, and then they need to reestablish inflow. And if they don't have a, you know, when they go back in and they don't have enough to sew to or provide, then they'll do a conduit
Sure. Okay.
for
Thank you.
inflow.
Yeah, that conduit looked huge too. It's like
Yeah,
a
it was,
usual.
and it was chronic. So this, like the transplant itself was remote. So the acute presentation was, I think, just the obstructive cholangiopathy.
I wonder if the biliary ischemia led to the stricture too. Like that area is already more vulnerable because it's an anastomosis, and then
Yeah, I that's, you know, that would make a lot of sense.
very interesting. I have never seen that kind of biliary ischemia necrosis. Okay, Omar.
Okay, so this is a postpartum female presented with uncontrollable vaginal bleeding following a very complicated vaginal delivery. They initially took her to IR and she got urinary artery embolization that stabilized her bleeding. And then OB surgically explored her and they saw uterine mass. And they got this pelvic MR to further characterize this mass. And so what we see. So this is her coronal T2. Sagittal T2.
Oh my goodness, what a great case.
Yeah, and a sagittal postpartum.
That's amazing.
Whoa.
This is the axial. So any ideas as to what this is?
So Arkansas is guessing uterine inversion.
Yeah.
So this is a very good case of complete uterine inversion, which is a surgical emergency with very high 24-hour mortality. So basically, essentially the fundus of the uterus herniates through the cervix into the vaginal canal. And there's different grades based on how much herniation occurs. You can have incomplete uterine inversion where the fundus just herniates into the endometrial cavity. And this is a case of complete uterine inversion where the fundus herniates directly into the upper vagina. And that's likely what they were seeing intraoperatively. And sometimes I was talking to the OB who took this patient to surgery. Sometimes the inversion itself is not readily apparent on surgical exploration, and they do ultrasound or cross-sectional imaging for further evaluation. So I took her back to the OR. They initially, to preserve her uterus, tried to balloon reduce the fundus the uterus back to its normal position. And they were successful, but if they were not, then the patient would need to have a hysterectomy to treat this. But yeah, very rare case. I think uterine inversion alone is very rare, but to see it on MR is also extremely rare.
Omar, how far postpartum was she?
She was 24 hours postpartum.
Wow. So was it something like the act of pushing out the baby, basically like the uterus just pushed itself out too?
So fundal implantation of the placenta increases your risk, and then excessive traction on the cord during placental delivery also increases your risk for it. So I think she had both of those. She did have fundal implantation of the placenta, and then her vaginal delivery was complicated, and they did mention they may have, getting the placenta out took a while, so I wonder if they did apply excessive traction on the placenta.
Wow.
Yeah. And that's it for me.
Great case.
Awesome, Omar. Thank you. Nelly, you're back.
Yep. So this is a patient with a mass. Any thoughts? I mean, you know, this is, I guess you just give a very long differential. This is a
I'm thinking
coronal.
like
So
neuroendocrine versus Asner.
great guesses. And I will tell you that this has been around for 4 or 5 years.
Can you scroll?
Here's the
some?
MR. What?
I was just asking to scroll. Swachchhanda is saying gist.
Great guess. And I'm showing this because I feel like we'll never see this ever again after this case is presented. Or maybe we will, because we see a lot of rare cases on this conference. So here's your T2. Here's in and opposed. No interlesional fat. Here are the dynamics. Okay, here's T1. It's ISO. And then here's arterial. Venous. So we went ahead and did it. Our gastroenterologist did an EUS, and this was a leiomyoma, a pancreatic leiomyoma. I don't think I would ever put that in my differential. But now that we've seen one, we kind of have an idea.
Wait, can you go back to the T2?
Yes.
If it was darker, maybe we would have brought it up.
I don't think it would ever preclude, tissue diagnosis in this case.
Agree. I was also thinking we could put in the differential paraganglioma and like schwannoma and stuff, but.
Great thoughts.
Okay, anyone else? I have some, but I will let anyone else go.
Aarti, I just joined in.
Oh, nice. Yeah, Victoria, great. Why don't you just start?
All right, so this is an outside study. It's a younger gentleman who had, can you hear me okay? So he had acute pancreatitis. And now I don't know exactly why the next study was done, but he had a MAR done the day after. So 1 day difference between the two studies. And now you can see that, actually this is a very pretty example of pancreatitis, interstitial edematous pancreatitis on the MAR. You can see that the pancreas is like abnormally high signal intensity. You see edema like dispersed and all these things. And then now we see this big hemorrhagic appearing collection. And here it is on coronal. You can see that it follows the curve of the duodenum right here. Let's see, this is in and out. So it's some sort of hemorrhagic. You can see it's bright on T1, doesn't have any fat drop. You can see that the patient's liver does drop here. So he probably has, he has fatty liver, he has pancreatitis, so he probably has alcohol disuse disorder. And anyway, so then this big collection. So I don't have a good answer for it, but it's some sort of, it's a very unusual rapid development for pancreatitis related collection, but it has to be something like that. So it looks like some sort of hemorrhagic process that dissected like along the wall of the duodenum. And this is just an unusual, I've never seen pancreatitis do this, but I guess maybe, one of these small vessels got eroded or something, and there's just a big duodenal hematoma as a complication of acute pancreatitis. And
actually, Victoria, that's a good point about it being in the wall, because we had a case similar to this and it was intramural, and that makes sense why it's staying in that location rather than just kind of like moving or spreading out, right? It's not intraluminal.
Right, and then if you can see the CT was done, sorry, I understand why. You can see that this CT was done a few days later, and again, you can see this collection is not changing. It's hemorrhagic, and again, it's like it's within the wall of the duodenum. It just follows that curve.
Yeah, you can see the lumen at the top of
Yeah.
it.
So anyway, so I've never seen this, but it looks like some sort of duodenal hematoma as a complication of acute pancreatitis. And then eventually it's like about a month later, it has resolved. And I'll show you that in 1 second. So you can see that a month later, it's pretty much resolved. We don't see this anymore. And remarkably, pancreas looks beautiful. You can see it looks really, really good. Anyway, so that was an interesting case. Next patient. Okay. All right, this patient was,
Yeah, I have a quick question.
what's up?
So it resolved or decreased in a month. So did the patient have an NG tube all those days? Because otherwise he would have ended up with a gastric outlet obstruction, right?
I don't know. So the images are from the outside institution. I just read the follow-up.
Oh, okay.
I don't know a lot of, but you're right. Let's see. Did he
Meaning
have
what kind of treatment? Did he have any treatment or they just let it resolve on its own?
it's the indication was just, history of thing. He did have NG tube right after this MR. No, it's a great point, but I don't know at what point they remove NG tube, but at the after this MR, it looks like they did put an NG tube, and you can see that at the time of the MR there was relative distension of the stomach. And it's a great point that this would cause gastric outlet obstruction. Okay, so the next patient was this, patient with advanced cirrhosis. Patient underwent liver transplant, and he ended up having an aneurysm at the. I don't have the images, that's why I'm telling you what happened to him. So he ended up having an aneurysm that ruptured and then had to have coiling. And this is what he ended up looking at like. And this was an interesting case because, so this whole thing is just a large, hematoma related to the prior rupture. But what's interesting here, which I've never seen, you can see that the left hepatic lobe is completely necrotic, even though the vessels still kind of go through it okay. You can see the discontinuity of the capsule. Here's a coronal. You can see that there's discontinuity of the capsule, so the necrotic liver parenchyma communicates with this perihepatic hematoma, which is, to be honest, I've never seen this before. So you can see again, like the areas of capsular discontinuity. So this is probably the most,
That's amazing.
Yeah, I mean, this is probably the worst case of liver necrosis I've ever seen.
So Victoria, you're thinking that the aneurysm ruptured, there was a hematoma, the hematoma liquefied, and then it just sort of like infiltrated into the liver, not that there's ischemia because they coiled off this aneurysm, because that usually doesn't happen, right? Is that what you're thinking?
I believe that, I assume, I don't have proof, but I assume that the parenchymal necrosis is related to either the aneurysm just knocking off the supply or them just knocking off the supply during angio. I don't think that hematoma, if the hematoma just ruptured into the liver, I don't think that, because the liver architecture is preserved, right? Like the vessels course through. It's not like, it doesn't look like the hematoma like ruptured into parenchyma and somehow compresses the parenchyma. There's no compression here. So I think that this whole segment basically, died, and maybe somehow the capsule got necrosed and disintegrated, and now you have communication between the necrotic parenchyma and the hematoma.
And what did they embolize? Which vessel?
Good question. Let me double check.
Like I saw some coils maybe in the region of the
So,
PDA or
so
hepatic
here,
artery.
so they did a hepatic, so he has transplant presenting with abdominal bleed. So we didn't have a cross-sectional study on that. So impression, successful covered staining of the proper hepatic artery to successfully exclude a 2.5 centimeter pseudoaneurysm, likely arising from arterial anastomosis. So they covered the proper hepatic artery.
Got it. That makes sense then, because they could have knocked off like an early branch to the left
Yeah.
lateral sector.
Yeah, and I don't have any, so there's no pre-embolization cross-sectional imaging. So, and the next imaging after the embolization is what I'm showing you right now. All right, that was the next. And then
There's a question in the chat. Any bile leak associated with the necrosis?
I think it's hard to say how much of that collection is hematoma, how much of it is bile. Yeah. So the next case is more of like, wow, amazing things can happen. So this is a patient who came in with abdominal pain to ED. And it's not an eye test. You can see a huge retroperitoneal hematoma. Patient actually, there's extravasation. So there's a, so this is a ruptured abdominal aortic aneurysm, with actual extravasation that we're looking at. The patient is 93 years old and she survived. So I think that's just a fairly unusual outcome when you have somebody who's ruptured their AAA. Okay. Any comments on that? It's a quick one.
No, I'm glad for her.
I know, pretty cool, huh? Okay, and the final case I have is, so this is a very interesting case. The patient had original tumor. He had, I think, RCC. Yes, RCC. And he presented with, I'm just going to, they did the study because they were concerned about duodenal perforation. So what you see is a thrombus in the IVC with foci of air. And as you follow it down, you can see it right there, that it communicates with the duodenum here, like peripherally. So this is a Duodenal-IVC fistula. I don't know, it's unclear, when I look through the chart, why he had the perforation, what predisposed him to, but they ended up putting a stent and they did an angio to clear out some of the clot, relatively successfully, because he was better on a follow-up study, which somehow, oh wait, this is the follow-up study. Sorry, I pulled up the wrong one. Here's the original one, where you can see that the clot even better. And again, you can see all of this. Wait a second, where's the subsequent one? Sorry about that.
There's stuff in the left renal fossa too. Is that post-op?
No, this is bowel.
Oh, just a bowel. Sorry.
Yeah. No, sorry. So this is the follow-up where they, based on report, it looks like they took out some of the IVC clot and angio, and then they placed a duodenal stent, and then they crossed the level of obstruction or fistula with the with the tube, and you can see that there's a little bit of this remaining and a little bit of clot remaining. So this was like kind of, I've never seen this before. I've seen duodenal aortic fistula once when I was a resident, and at the time my attending said, "You will never see this again," and she was right. but this is Duodenal-IVC fistula, which I also have never seen before until this time. That's
awesome. Victoria, what is that stuff going on in the liver? That's unrelated.
Oh, these are meds.
Okay.
So he had meds. Some of these are meds. This fiducial markers. So he's not a healthy man. He had PE. I don't like the indication for this CT. Literally said that they're concerned with duodenal perforation, but why? Like, what made them think of that? I don't know.
It looks like there's a clip in the duodenum there. Like maybe they did an EGD and they clipped off an ulcer or something.
It's possible. That's the history of metastatic RCC, admission for bacteremia, evaluation of hematemesis versus hemoptysis. Well, he actually, at that time, they already knew that he's on nivolumab, carzinib, bacteremia, discharged, recurrent fevers and bacteremia. Now with concern for duodenal-IVC fistula, I'm not sure why they decided, what made them concerned about that clinically, but that's, whoever was concerned about it was right.
Awesome. That was a whole slew of interesting cases.
All right. Okay.
Anyone else? Just going to pause this for. Okay, so this is a 60-year-old female. With this mass.
Let me see the corona.
Yes. I don't know where the coronal venous is. It seems to be missing, but here it is on the arterial phase. And someone has chatted in, but I can't see the chat. So if you can just tell me what they said.
There's nothing on the chat.
Okay.
Unless
chat
we're showing us saying GIST.
Okay. Good. That's a great thought.
How does it relate to pancreas?
That's also a great thought. So pancreas is here.
Could it be SPEN or whatever it's called now?
Is it called something different?
I think so. I think they changed the name from SPEN to some other acronym.
Huh. Okay, so SPEN's a great thought, solid pseudopapillary neoplasm, and they could have solid peripheral parts with internal hemorrhage. And then GIST is also a great thought. It looks like it's affiliated with the stomach. I'm going to show you a companion case. So this is my companion case. This one also has liver lesions. Ignore the liver for now and just look at the mass.
Cystic neuroendocrine tumor.
Okay, so this one also solid cystic, and the pancreas is there, smushed, but maybe it's affiliated with the pancreas, and it could also be affiliated with the stomach. Okay, so I'll just cut to the chase. This one was a GIST tumor arising from the stomach, right there, and extending down into the mesentery with liver metastases. And I'll come back to this case in a few minutes. And then this one was actually a pancreatic tumor. Does anyone have any other guesses aside from a SPEN?
Neuroendocrine.
Okay, that's also a great thought. Those two would have been my top two, and then anything else? For like a well-encapsulated, solid and cystic kind of mass, older patient. So this was an acinar tumor. So I have a few cases of acinar tumors. I just wanted to show you this one because this one is the most classic one of the ones that I have. But anyway, acinar tumors are arise from the acinar cells of the pancreas, which are the ones that make amylase and lipase. They're actually the majority of the cells of the pancreas. So these tumors, when they're small, they can be more solid. And as they grow larger, they can be more necrotic and have this kind of central necrosis. About 50% of them will calcify. And they are fairly aggressive, but have a better prognosis than adenocarcinoma. And because they're from acinar cells, they can lead to a paraneoplastic syndrome where you release lipase into the blood, and you can end up with fat necrosis in your skin and also your bones. It has a male predominance, so it's like 4 times more in males, but this was a female with an acinar cell. So, and it's usually in patients over the age of 60. So this patient, they resected her pancreatic tail acinar cell tumor, and which is the treatment if it's restricted the pancreas. She developed liver metastases about a year later. But they're actually now treating these liver metastases with chemo, and they're actually shrinking. So, and you can see she had a distal pancreatectomy. So this patient had acinar cell. This is a companion case of a patient who had a distal pancreatectomy, also for an acinar cell. I don't have the original imaging because it was done somewhere else. And then later presented with this liver lesion. You can see it looks a lot like the other person's tumor, where it's solid on the outside, hemorrhagic on the inside. So this was her liver met from acinar cell. And then this is a third patient with acinar cell. And his tumor is very interesting. It's actually still in place, and it is this cuff here. This is biopsy proven pancreatic acinar cell. Acinar cell is usually, it actually predominates in the head, but it can be anywhere in the pancreas, but it's usually large, exophytic, and heterogeneous. More rarely, it's smaller, and even more rarely, it can cause biliary obstruction. In this case, I think it was a pretty aggressive one because this tumor has all of these liver mets. This is the arterial phase. This is the venous phase. When I saw these, I saw like capsular retraction, you know, kind of lesions that have central scar, multiple. So if I'd just seen like one of these, you know, this could have been a good look for cholangio, but with multiple, we're thinking metastatic disease. I thought about colon cancer mets, but in the end, these were acinar mets. So I thought it was interesting because like between the first 2 cases, I was like, okay, when they get big, they get necrotic. I could recognize that now, but then this one had a different pattern. So any comments about acinar? I think the take home actually would be that generally, especially if you look in the literature, especially when they're larger, they look more like this kind of lesion.
The case of acinar that I've seen, it didn't look capsulated. It was more infiltrative.
Yeah, I think what I'm realizing is it can be a range, but there was a series I read in I think it was AJR. It was from the AFIP, and they had like 102 cases or whatever, and they said their conclusions were that the average size was 10 centimeters. They tend to be heterogeneous. They tend to have central necrosis, and they tend to be well circumscribed, ovoid or round, and 50% will calcify. So I don't know, but I think, yeah, the last case I showed you shows that there can be some variation, and it can be more infiltrative. And then I just thought this was interesting because like, then, you know, I saw this case and I was like, oh, is this an acinar cell? But it does look a little different. The kind of periphery enhancing component isn't as papillary looking. But anyway, this turned out to be a GIST. You can see they have a lot of liver mets for this GIST. So they treated this patient with Gleevec, and this was their follow-up scan. So you can see that the primary GIST tumor has decreased in size, so it's responded to the Gleevec. And the liver lesions have also decreased in size and become cystic. So whenever you see it's like cystic looking lesions, but the patient has a pretty aggressive GIST, always go back in time and see if maybe those were actually METs, because when they get treated, they liquefy and they look very much like cysts. The patient continued on their Gleevec. They were on maintenance Gleevec. And this was their latest scan, where you can see that the liver mets still look like cystic, but the primary tumor has now massively increased in size. Now it's about 20 centimeters. And basically what's happened is that in this initial period, it was probably that it still had a c-KIT mutation and was responsive to the Gleevec. Therefore, it was under control and it was responding. But sometimes over maintenance, over the long term, they start mutating, they lose their c-KIT mutation. They're no longer responsive to the Gleevec, they become higher grade and they start growing. In this case, because it was causing a lot of symptoms and mass effect, they actually resected this, this enormous tumor at this point. So just kind of the natural progression of an aggressive GIST. Okay, this is my last case. This is a patient who has a positive HCG. So we're thinking she was pregnant, but on ultrasound, there was no intrauterine pregnancy, and there was a lot of complex fluid in the abdomen. You can see all of that complex fluid here around the liver, extending into the pelvis. Here's the uterus. There's no intrauterine pregnancy that we can see. This is one ovary. This is the other ovary. And there was this complex structure here in the right adnexa. So we couldn't say this looked like a gestational sac, but we did say, you know, there was a complex mass looking thing in the right adnexa, and there's massive hemoperitoneum. And so basically this is a ruptured ectopic until proven otherwise. And I'll show you that structure again here. So this is the ovary on one side, on the other side, and then this was the structure in the right adnexa. The patient went to the OR, and this was a ruptured tubal ectopic with massive hemoperitoneum. Any questions? Okay.
I have one case left.
Okay, go.
Okay. This is a patient with PSC. Here, I'll give you the pre-transplant MR. This is your arterial. And venous. MRCP for fun.
That's a really nice MRCP for PSC.
It's beautiful, isn't it? Here, let me give you the
Yeah, I like
MIPS.
the, like you can see the beating nicely.
Yeah, it's a really nice example. And then so it was, you know, sequelae of PSC. We didn't see any suspicious lesion. And then the explant came back with multifocal cholangiocarcinoma. 3.5 centimeters, 3.8 centimeters, multifocal places. And this is such a humbling, because I would still call this negative. And it made me realize how hard cholangiols are.
Did they say anything about like superficial, like is it like a superficial spreading cholangio, or is there an actual mass that we just can't see here? Like a rounded mass, or
mass forming, multifocal mass forming. Yep, biliary cirrhosis. Yeah, so it was mass forming. It wasn't a, you know, it wasn't a ductal, intraductal
Wow. And nothing on diffusion?
Where is my, here it is, here's my diffusion. Kind of unremarkable.
That is really scary.
Isn't it scary? And then this, I mean, we have a CT too before transplant, and same thing, nothing that I would call multifocal cholangio.
Wow. I feel like more often we are worried about like peribiliary thickening in patients with PSC, and they do like lots and lots of brushings and it never comes back with malignancy, and then they're just stable over time. So I feel like, I don't know what to take away from this.
And I mean, we do screening MRs all the time for PSC patients, you know, and I don't know. I mean, this is like the second case where there was like a cholangio that just wasn't really visible on MR. Anywho.
Okay, anyone else? It was great to have you back, Omar. That was an amazing case of uterine inversion. Now I want you to come back every week.
Thanks. Yeah, I'll definitely try. I'm rarely off on Tuesday, so I'll try.
Cool. Okay, have a great week, everyone. See ya.
Thanks all.
Okay, bye guys. Good cases.